Hope we are more than halfway through our program. Hope all of you are imbibing everything and getting there to start practicing soon. And today, a warm welcome to Dr. Rajam Iyer. We have an important topic. I keep on telling, like, see, in palliative care, pain and breathlessness are the two, like they say 80 to 85% of the symptoms which needs to be taken care of are these. So for that, we have an expert faculty. Dr. Rajam Iyer is a pulmonologist and a palliative care physician, practicing extensively in Mumbai, both at Bhatia and the Hinduja hospitals. And she has obtained her palliative care fellowship also from Cardiff University. She's been the recipient of the Har Gobind Award, and she's published many papers, I would say, from general clinical issues in pulmonology to oncology and guidelines, and most difficult symptom, tricough or cough in pulmonology is a challenging symptom. So she has not left any stone unturned, I think, in pulmonology. So like that, she has an extensive publications under her banner, and she is practicing, and she's an ardent person who wants to implement palliative care also. So with that, I pass it on to you, Dr. Rajam Iyer, to take us through our session today.
Thank you, Radha. Very, very kind words. And it's nice to see a familiar face in this group. In fact, I didn't even recognize the person from Pallium because I thought there'll be a familiar face there. But it's good to see you, Radha. And I think last time I missed on meeting your family in Chennai, but maybe next time we should meet in Chennai when you are next.
Yes, so, yes, definitely.
A very good evening to all of you. And as Radha mentioned, I heard her say that you all are already halfway through your, the training. That means you are already there, and you must have heard a lot of words that I am going to use, but I'm going to try and focus on the respiratory aspects and why we need palliative care in respiratory medicine. So a simple request, please stop me if there's any doubt, or if you want to share something, or there's any clarification, or if you want, you can put it on the chat. Either Radha or me will see that and answer. The more interactive it is, the more interesting it is. And also I'll end up learning some things from you. And I hope you do too. So with no further waste of time, I know you all have had a busy work day. I'm going to share my screen and start my slides. Please don't worry about the number of slides. I'm not going to show you all of those. And like I said, I would like to keep it as minimum as possible. And I want to talk as less as I can. And I've just started my timer also so that I'm not overshot. So all of you must have, listened to other doctors about palliative care, and the fact that a large number of people, close to what I can say, 30 people are online today, that your interest is still very much alive, and I'm grateful for that. So when we talk of respiratory medicine and palliative care, there is one thing that I really need to start with. The point is, you must have all heard that palliative care historically started for the treatment of patients with cancer, and not just cancer, patients who are dying of cancer. Hence, unfortunately, palliative care is often misunderstood even today to be something meant for cancer patients only, and for those patients at end of life, both of which is not true. And one of the slides that actually helps us understand this better is today, if you see the number of chronic conditions that is suffered in India, a lot of these chronic conditions are lifestyle diseases. So for example, blood sugar, high blood pressure, dyslipidemia, smoking related COPD, tuberculosis, interstitial lung disease, cardiac events, cerebrovascular events. So all these are chronic conditions which actually affect a large number of Indians. Yes, we do add cancer patients, about 1 million cancer patients every year, but that is nothing compared to the number of Indians who are already suffering these chronic illnesses. And as doctors, you will all appreciate the fact that we are able to cure only 1/3 of the conditions, correct? So if you all put your head together, can you in the chat box send me those conditions in the respiratory disease that you're able to completely cure? There are 1/3 conditions which we are able to control, like asthma. There are 1/3 conditions which is incurable or uncontrollable, like probably interstitial lung disease, advanced COPD, as well as certain forms of lung cancer. So which are the conditions in respiratory medicine that we are able to completely cure? And if you think of all other systems, neurology, gastroenterology, cardiology, we are able to cure only 1/3 of our patients. The rest of the 2/3, we are hand-holding them, we are counseling them, we are only able to control, or it's incurable. Therefore, bulk of the conditions that we see needs palliative care. What is the meaning of hand-holding? It is just trying to control emotions, physical symptoms, sugar levels, blood pressure levels. So you must remember, as a doctor, every doctor needs to be trained in palliative care, and you need to wear your palliative care hat appropriately, because every condition is not cured by us. Okay. In respiratory medicine, this graph is just to show you that all common conditions, be it COPD, be it TB, and be it asthma, be it interstitial lung disease, the incidence of these situations are on the rise. In India, it's complicated by domestic air pollution also. So please remember that the global burden of respiratory conditions, India shares 1/3 of the global burden of respiratory conditions. So the world's 1/3 of the illness is in this country. Also, now we are the most populous country of this world. So combined with the fact that so much of, because of the fact of domestic pollution, cigarette smoking, late diagnosis in tuberculosis, poor diagnosis, poor adherence to treatment, we have a lot of burden of chronic respiratory conditions. Now, all of you by now must also be familiar by this graph. Am I right? You must have seen this graph before. And this is just to highlight graph C. And when I mean by saying graph C, that is exactly where our patients with chronic illnesses and chronic organ failures fall in. So if you see this graph, these patients of so-called non-cancer chronic conditions, or you could say non-communicable diseases, or focus on COPD and ILD. These patients get diagnosed fairly early. COPD gets diagnosed at the age of 60 or 65. These patients then lead a very prolonged period of life with a high symptom burden, say 10, 15 years. And every time he visits the hospital, it's only for an emergency. So pulmonologist or intensivist see this patient in an emergency. And every time he goes home, you will realize that his quality of life is nowhere compared to what it was at the time of diagnosis. So this man is slowly fading, slowly worsening, and it is probably going unnoticed because the pace is spread over 10 to 15 years. Typically, hospital consultants see these patients only in acute exacerbations. So when these patients go home, we don't even know whether these patients are self-caring, they're able to walk to the toilet, are they able to eat on their own, are they able to talk full sentences, are they taking medications correctly, inhalers, nebulizers. So many things are happening when a patient goes home discharged from the hospital. So unfortunately, non-communicable diseases or non-cancer conditions are not perceived as life-threatening. What do I mean by this? Is that if you diagnose a patient to have lung cancer, the next question in his mind is, how long do I have to live? But if you diagnose a patient to have COPD or interstitial lung disease, that is not the next question he asks, because he is not explained about the fact that this condition is incurable and that this condition is progressive. He feels the doctor is giving him treatment and he will get better. And there is no other worry at all. So we also as doctors need to realize that it is our onus as respiratory physicians to be to be able to foresee and foretell, to describe the trajectory of patients' illnesses, so they are better prepared and they're also better, they know what to expect from their condition. Okay, so it's very important uh, to remember that non-cancer conditions get fewer referrals to palliative care. They're not perceived as life-limiting. They lead a very long period of time with a very high symptom burden. Any questions or doubts? So if you think of any chronic lung disease or any chronic illness for that matter, it is like falling off a skyscraper. So please remember, as the patient is worsening, I was telling you, it is our onus as doctors, because we have seen more than 100 COPDs, no more than 100 interstitial lung disease. It is our onus to educate patients with timely, unhurried, sensitive conversations. We should not wait for the patient to reach such a stage that now we say that we cannot do anything. Very often we hear that, or we also hear residents saying that if we don't admit in ICU and we don't put on the ventilator, your patient will die. This is not the way to communicate. This patient has been deteriorating for a long time, and yet we haven't taken the responsibility to warn them. Because the manner in which you land depends on the way you fall. And if this fall is punctuated with good conversations, with expecting the patients, explaining to the patients and family what to expect, clearly they are better prepared. But it has to be done in a very sensitive way, in a language they understand. So that is where we come in as respiratory palliative care physicians, where we would like to integrate this palliative care, when we can offer some treatments to the patient and gradually work as a team. As the patient's condition worsens, the palliative care options become more and the curative options fade away. It is important because the patient doesn't feel abandoned. Very often now it is happens so that the pulmonologist treats the patient till really nothing can be done. The pulmonologist is so frustrated, saying, now you go and meet this lady. The patient feels, this doctor of mine for the past 5 years or 10 years is now suddenly sending me to somebody else. Why should I go to that person? So it has to be shared care. It has to be a smooth transition so that these patients also feel cared for and their treatments are not abruptly ended and started. And the beauty of palliative care is that we not only look after the patients and their caregivers during the treatment, but at the time of actively dying or at end of life, and also bereavement. Imagine looking after a patient for 10 to 15 years, and on the death of that patient, it is a big void for the caregivers. It's been difficult journey for the caregivers too, and we are not able to, we should be acknowledging their hard work also. Okay. The most important thing that pulmonologists ask is, if I refer to palliative care very early, that means the patient feels I am giving up or loses hope. And it almost always the referral is so late that there is no time for me to form a rapport with the patient, to explain what I can do to make the quality of life of that patient better. So the timing of the referral is very, very important. And it's a very much researched question in England. So if you are sitting in your outpatient clinic and you have a patient of advanced COPD, or you have a patient of advanced chronic respiratory condition, you think in your mind, he's on oxygen, he's barely able to complete a sentence, he's barely able to move, he's got multiple hospital admissions, he's got multiple comorbidities. You, with your clinical acumen and clinical experience, will be able to tell whether this patient will be alive to see the next Christmas or next Diwali. If in your mind, the answer to that question is no, that is the time for proactive palliative care. It's a very simple thing. In your mind, you think, this is an elderly person, so many comorbidities, multiple admissions, one admission to the ICU, 24-hour oxygen, so many medications, still so breathless. And then you think, this is the time for this patient. He might not see the next year. It is time for proactive. This gives you enough time for the patient to get to know you, your relatives to get to know you, discussing all the issues, the problems, the logistics, whom to contact in an emergency, what to do in an emergency, where to come, where not to come, to get admitted in ICU or not, to be ventilated or not. All these discussions, all these points can be discussed. Any thoughts or anything you all want to share at this point, or shall I continue? Okay. So again, there are two documents which I would request all of you to read, both of which Pallium India can share it with you. One is the gold standard framework, and second is the blue maple document, which is made in Manipal. This both documents actually list out indicators for palliative care referral in every chronic condition. So right from CKD, dementia, Parkinson's, motor neuron, chronic respiratory diseases, chronic renal and chronic liver. So everything is listed. So if your patient I have picked up the criteria for referral for COPD. If your patient satisfies any two of these following criteria, which is number of hospital admissions, when the breathlessness grade is MRC 4 to 5, when the patient is worsening pulmonary function test, continuous oxygen, maybe using NIV, ICU admissions, severe comorbidity. It's not even that the patient has to satisfy all these criteria. Any two is enough to start the referral, because the prognosis of this patient is poor, and it's important to realize that this person will deteriorate. So it is important to understand to go. I request Pallium to please send you those two documents, because then it becomes easy for you to refer patients and integrate palliative care at an earlier stage. So these are the two documents which Pallium India will share. Another interesting highlight to show you here is that despite the West, the amount of integration of palliative care is fairly good in the mainstream. Still, a study showed that 80% of cancer patients got palliative care, and only less than 2% of patients with COPD or advanced chronic lung got palliative care. So it's long time to go. Another sad thing is those patients with advanced chronic lung disease who got admitted in the ICU, they were the ones who, despite no curative treatment, were subjected to more aggressive invasive treatment. Their distressing symptoms were less documented, therefore their distressing symptoms were less treated, and they basically died a poor quality death along with more CPR. So there was no dignity in the quality of death. It is important to realize that cancer patients get at least more referrals to palliative care, whereas COPD and interstitial lung disease don't. And the sad part is that even the fact of unnecessary invasive treatment, ICU, intubation, dialysis, CPR are subjected to more because it's available. The point is, we need to think of the medical ethics. Is this what the patient wanted? Is this in the best interest of our patient? Are we doing harm to our patient? And therefore, is there justice? So just because a person can afford treatment doesn't mean he gets subjected to A, B, C, D, because it's available in an urban metro of India. The other thing which we never realize is when we send patients home from the ICU, we feel, yes, he survived, he's gone home. So we equate quality of life to survival. But please remember, the focus should be on quality of life and not quantity of life. Because in a follow-up study of patients who were admitted with COPD, 25% of patients were only alive and well with decent quality of life. Almost 50 were readmitted, and the 25 were dead on going home. So the fact that the patient survived your shift doesn't mean he's going to survive life with a good quality of life. And once you leave ICU, even during COVID times, you must have seen that patients go through a lot of stress, which is equivalent to a post-traumatic stress disorder, of how he survived the ICU, the nights in the ICU, the beeping machines, of how his arms and legs are bruised. So it's not just the physical trauma, but it's the total pain, financial, social, emotional, that the patient goes through. We must select patients well before we put in ICU. And just because we have an ICU and just because the corporate hospitals have a different way of functioning shouldn't be the reason to keep admitting patients in the ICU. So there you go. The mortality after admitting these patients is also fairly high. So coming to the main symptom like Radha described. So till now, I was trying to emphasize on the need for palliative care in respiratory medicine. It is nothing not different on how our patients suffer during the journey of their illness and even at the time of death. Now, all of you know this, that when you have a patient of breathlessness, you will do a detailed history, you will do all these investigations. Now, the two investigations that is important that you need to do is arterial blood gas, because X-ray, ECG, 2D echo, everybody does. Bloods, everybody do. Arterial blood gas is important. It reflects the health of the lung with the respect to the pH, the carbon dioxide and the oxygen, and the pulmonary function test. Very, very important to tell you whether it's obstructive, whether it's restrictive, what is the situation of the diffusion capacity. So it gives you a lot, and it is not a very well utilized and very well performed test. About pulmonary function test, details is actually an entire class on its own. But if you all are interested, we will definitely let you know. Now, in our history taking, when you're asked about patients with breathlessness, we often stop with, is your breathlessness better? Are you taking the inhalers? What makes you breathless? What relieves your breathlessness? But just imagine a patient who is breathless every single minute, 24 hours a day, day after day, week after week, and year after year. So for this, I'll request you to do a small exercise with me. So if you all can sit straight on your chair, okay? Take a deep breath in and blow only half out. So take a deep breath in, blow half, and take a deep breath in and blow half. Do this for the next 10, 12 seconds and see how you feel at the end of that breath. You want to breathe out with an exact. This is how our patients feel all the time when they are not able to take a deep breath. So imagine feeling like this every single moment of your life. The issues with breathlessness is something we never ask our patients. For example, the frustration, the dependence, the anger, the inability to do things on your own, the fact that at one point you were running the house and now you're nobody and nobody asks you for anything. So we need to train ourselves as palliative care physicians to ask these questions. Are you coping? Our history taking has to change, and it has to say, what have you given up because of your breathlessness? What is it that you have stopped doing because of your breathlessness? And that is when the answers will come. I can't even go to the toilet on my own. I can't take a bath. I can't change clothes. I can't go and play with my granddaughter. I can't go gardening. I can't do my shopping. So many things will come. We only ask closed questions. Are you breathless? Are you better? And that's when our consultation ends. If you change the way you ask questions, it is going to make a big difference. And that is when all the patient complaints come. I can't do this. I'm dependent. I'm a burden on my family. And that's when you realize that breathlessness is not just a physical symptom. When a person is breathless due to any chronic advanced condition, it can really affect him psychosocially, emotionally. And many often it has been described that patients of respiratory conditions die a social death before a physical one. They're isolated in their houses, they are bedbound, they are housebound, like how we were in COVID, and it can be really distressing for our patients, right? So our patients, therefore, to describe it even better, are actually stuck in this breathing, thinking, functioning vicious cycle. Because of the underlying pathophysiology, patient is breathless, there's an increased work of breathing, and their respiratory rate is high, and they're constantly huffing and puffing. When your respiratory rate increases, you automatically become anxious. The thought, the fear of death, oh God, what is happening to me? So, and the only thing that is working overtime is your mind. So you have a breathless patient who in turn feeds into the anxiety. Now, with those two in combination, the patient is so petrified to move that he keeps sitting in the place. And what happens when patients sit in one place? They lose muscle mass, because if you don't use the muscles, you lose the muscle. So our patients now become deconditioned. So the biceps, the quadriceps, the hamstring, everything becomes useless and weak. So now if the patient is even attempting to do something on his own, he is so breathless that he gets stuck in this vicious cycle. Breathless because of underlying condition, worsened with the fear, anxiety of the mind, and also the deconditioning because he doesn't move at all. The beauty of integrating palliative care here is that the pulmonologist looks after the breathing, the physiotherapist looks after the deconditioning and slowly builds up the exercise, stamina and endurance, relaxation techniques, and the psychologist deals with what is happening. So it's a beautiful multidisciplinary team which helps the patient and the caregivers, because sometimes patients feel very intimidated to ask you and me questions. They're happier talking to paramedical staff. They're happier talking to nurses. So palliative care is a beautiful mix of all these people so that there's a safety net and our patients can ask the most smallest of questions so that their issues are addressed. And therefore, if proper medication is given for the breathing, counseling for the mind, and also exercises, simple graded exercise, it will also help the patient do his activities of daily living with less effort. So, for example, if you and me want to train for a marathon, we start training 1 kilometer, 2 kilometer, 3 kilometer, and eventually are able to run 21 kilometers. Similarly, if we train our patients with in patients who are chronically breathless, they are able to do things like going to the toilet, taking a bath, or talking on the phone full sentences, eating with family. For them, these issues are marathon. We need to therefore focus on their quality of life. Let them be able to do small activities which give them joy with less effort. And that should be our aim. And that is the ethos of palliative care. So that brings me to the definition of chronic breathlessness syndrome. Our patients who have chronic advanced lung disease have this condition, which is coined as chronic breathlessness, which is patients who remain breathlessness despite maximum medical treatment for their condition. And when this breathlessness affects them psychosocially, emotionally, that is chronic breathlessness syndrome. So not all patients will fit into chronic breathlessness. You need to evaluate. The pulmonologist, the cardiologist, oncologist need to start asking, and you see that the patient is breathless at rest or at minimum exertion despite maximum medical treatment, that is the time you label the patient chronic breathlessness. And how does this help? Because we can then help the patient both with non-pharmacological and pharmacological interventions. So simple things like positioning of the patient, loose clothes, stand near a window, blowing a battery-operated fan on the face. Just a 30 rupee battery-operated fan decreases the sensation of breathlessness. And today, if you Google search battery-operated fan plus chronic breathlessness, there are research articles of how easily caregivers cannot panic and help their patients before rushing to get to the ambulance and go admitting in the emergency room. Secondly, when suppose patients enjoy cooking or patients enjoy gardening, they should have somebody to supervise them and somebody to help them plan, prioritize, and pace their activities. So, for example, somebody can help them with keeping the kadai, getting the oil, the spices, the cut vegetables, so that the person concerned can sit and do that, make that preparation so that he or she also gets the joy that I'm able to do this cooking. I cook this vegetable for my family, or I cook this dal. So let them still have the power and let them be able to choose what they are able to do and not able to do. So non-pharmacological, okay. Parvati is saying about the International Delphi. So you know how the Delphi process is, right, Parvati? When you have a group of expert people who give you the opinion of what it should be, and that becomes the process in which the definition is formed. So it was an International Delphi which coined the word of chronic breathlessness. It's a process, a statistical process of making this definition. Am I clear?
Sorry
Yes,
to
ma'am.
interrupt.
Yeah.
There's a question. I think regarding the third point in the Delphi, I think she's trying to talk.
Yeah.
If you don't mind.
Yeah, I just didn't understand the third point, which says about the duration of the breathlessness.
Yeah. So the duration of the breathlessness means if you have a patient, irrespective whether it's 1 hour, 1 week, 1 month, 1 year, in this situation of being breathless despite medical treatment in affecting his psychosocial health, that patient has chronic breathlessness. You understand? See, when we say chronic, for example, when we in MBBS, when we were taught chronic, anything more than 3 months. Correct? Acute is when the patient had and didn't have. So in chronic breathlessness, this is a condition which the patient is actually having that illness for a long time. And despite maximum medical treatment, irrespective of whether the patient is breathless for 1 day, 1 hour, 1 week, 1 month, it is chronic breathlessness. You understand?
Okay, thank you, ma'am.
Yeah. Okay. So non-pharmacology comes in a long way. The physiotherapist can actually teach the patient some relaxation techniques. The relatives can do some massage, some music, some pet therapy, and all, like I told you, the handheld battery operated fan. Please do this homework and please share amongst yourself the beautiful articles which actually say that the 30 rupees or 60 rupees operated fan can actually prevent a lot of casualty visits and a lot of unnecessary ICU admissions. Okay. And then after that is the pharmacology. Now, you all know how to treat breathlessness, whether it's diuretics, bronchodilators, steroids, nebulizers, all of that, you know. Point here that we need to talk about is oxygen. Very, very important. And we saw what happened in the wave 2 of COVID by using oxygen unnecessarily. Oxygen is also a drug. Yes, it is a very important drug for the body to function, but unnecessary oxygen also can damage the lung with a nascent free radical. So when your oxygen saturation is above 88, do not give the patient oxygen even if he is breathless. Because the cause for breathlessness could be anxiety, could be pain, could be some bad news, could be fear, could be anything. So first, try non-pharmacological. Even after that, check if the oxygen saturation is not below 88, do not give oxygen. Because in certain patients, like COPD patients, yanking up oxygen can also be dangerous because carbon dioxide also starts building up. And this patient, you will see, suddenly starts becoming more and more drowsy. So please discuss with the pulmonologist what are the indications for oxygen, when should you increase the oxygen, and you must try non-pharmacological when these patients get acutely breathless. The second and the most important thing, which is important as a palliative care physician, is low dose opioids. Yes, very often pulmonologists also fall off their chairs when we talk about morphine. Morphine is a centrally acting drug. Morphine in pain is very different action. In breathlessness, we give a very, very tiny dose. We start with 2.5 milligrams twice a day and gradually review the patient and increase the medications. So the advantage of morphine, because it acts on the central, it decreases the respiratory rate. And we give such a small dose that it doesn't knock off the patient. It just makes him less breathless. And how? It decreases the sensation of breathlessness. It doesn't bronchodilate. It doesn't remove the fluid from the alveoli. It's not a phosphodiesterase inhibitor. It just reduces the signals from the respiratory center. It reduces the work of breathing. So patients start having better tidal volumes, better depth of respiration, and less anxious, and therefore they're more calmer. And I have patients who come on the wheelchair for the first consultation, and subsequently they actually have time to dress up and walk from the car park or from the bus stop to the clinic on their own. So you actually are making a difference by improving their quality of life. So they say simple things like, I could now manage to go to the toilet on my own, or I can eat, without stopping and coughing. I eat with my family at the dining table and not in my room. In these 5 to 6 years, I haven't seen any situation where morphine causes respiratory depression and death. We do not give more than 30 milligrams of morphine in 24 hours for breathlessness. And to be honest, I have never crossed 20 either. Abroad, most of the literature says of sustained release morphine, but I use immediate release, and I have gone maximum up to 20 milligrams of morphine. Patients actually have 80% of the patient have given the feedback about how their quality of life has improved. I've had patients in a survey done who live for 8 to 9 months after initiation of morphine, and they die peacefully because in that time we have had enough discussions about how they would like to be treated at end of life, where they would like to be treated, and by whom. So all these discussions are done. It is hard. It is not easy to have these discussions, but it's better to have it than not at all, and better to do it when the sea is calm rather than in a storm. So please remember, it's a wonder drug. It has a great statistical significance on how the patient feels, and there is no instance of high carb. So even if the patient has type 2 respiratory failure, you can use morphine along with NIV if the patient is happy to use the NIV. Okay. Then morphine is also very useful in terminal breathlessness. That is not just in respiratory, but it could be congestive cardiac failure, it could be CKD, it could be terminal oncology patients where we aggressively control the symptoms by infusion of morphine and midazolam and see to it that the patient transitions in peace. This has to be done by strict identification of which patient to be selected, talk to the patient, talk to the family, document it, have the GP or in the hospital on board, and we give it through a subcutaneous syringe pump at a very, very slow dose of 10 milligrams of morphine and 5 milligrams of midazolam over 24 hours. And usually the patient is, started within the last 2-3 days of life, so that the patient is not struggling and the family also doesn't have to watch the patient struggle. The patient is in sedation and transitions in peace. There's a question.
One question.
Arora, if the patient is already on morphine 10 milligram for pain, and if the patient is breathless, then I think you need to assess the other reasons why this patient is breathless before you start doing anything with morphine and breathlessness. If the patient is already on pain, then you need to assess, explore his fears, anxiety, beliefs, something else that's bothering him. Start the physio before you do anything with morphine. So am I clear there? Okay, so please remember, terminal breathlessness, again, very often important because the manner in which a loved one dies is etched in the memory of those who live on. So for the sake of the fact that our caregivers shouldn't, live with this burden and that our patient doesn't suffer, you must aggressively think of discussing terminal breathlessness also with your patients, which we do quite commonly. So please remember, it is a thing which is done for comfort. Yes, the side effect is death, but it is given in patients who are imminently dying or actively dying. It is medico-legally allowed because it is in the best interest of the patient with the consent of the patient or the family. And it is important to have clear communication and documentation. So please remember, this is not unethical. This is not euthanasia. You're not giving a whopping dose of a medication to end life. You are giving small doses of medication to comfort the person till he dies. So there's a big, big difference. And I'm happy to take questions if there are any. Okay, so just going through other symptoms, cough, which is a protective reflex, but when it's persistent, it can be very, very distressing. Again, we focus, must not be just respiratory, because it could be cardiac, ENT, upper respiratory, drugs, treatment, psychogenic. So explore your history properly. Next, any persistent cough in an underlying chronic advanced lung disease, you must think of non-pharmacological first, like I told you. So, lifestyle habits, eat early light dinner, 3-hour gap, small frequent meals, those kind of things, hot water. And then pharmacologically, what we try and do is first the codeine, then introduce the morphine. And then now there has been results of drugs like gabapentin, which has been useful in patients with chronic, distressing, intractable cough. So we start with 100 milligrams in the night and then slowly increase to 300 to 600, because one of the side effects of this medication is drowsiness. Patients report well. How to step up dose of morphine? Yes. So Deepa, what we do is we start with 2.5 milligrams 12 hourly with laxative, because morphine at any dose causes constipation and a patient with chronic breathlessness cannot afford to be constipated. So once the patient benefits from it or reports being a little bit better, we make it 8 hourly, then 6 hourly, and then 4 hourly. And each of the times we tell them he can take an extra dose. So before a bath, he can take the 2.5, or before he's going to do an activity like physiotherapy, etc., he can take a 2.5 as an SOS if he's needed. And strictly, we do not go more than 30. And I have never needed more than 20 to 25 milligrams of morphine. We are happy to share articles if you all are interested of chronic breathlessness with morphine. Low dose opioids are extremely safe and it has to be done responsibly. You need to keep a list of patients you have given the low dose opioids and keep in touch with them if they do not report back to you. Okay. Similarly, like I said, so codeine, then morphine, then gabapentin for chronic cough. Okay. Then pleural effusion, again, a very common thing seen by pulmonologists where repeated filling is very distressing for the patient. Most common cause is cancer, and we therefore need to treat with respect to the prognosis of the patient. So if the prognosis of the patient is good, we can put an indwelling pigtail catheter. Sorry. If the prognosis is poor, then we advise one-time aspiration and then control of symptoms like with morphine. So please remember, again, assessment, history taking, and what the patient understands and wants is very, very important before you dish out a prescription. So this is what I said, depends on the prognosis of the patient. Hemoptysis, again, scary. Some patients, we should be preparing them that this might happen. So they need to keep dark towels. Sometimes in hemoptysis, the fear is dying of aspiration of the blood and not necessarily loss of blood. And therefore, when these communications are important, patients need to have contact numbers of tertiary level hospitals where complicated procedures like bronchial artery embolization, laser ablation, cryosurgery, brachytherapy can be done. So these things need to go with the discharge of the patient if you're anticipating hemoptysis. Okay. So very important, and we can do rigid bronchoscopy, we use adrenaline, we can use tranexamic acid. We also give the patient tranexamic acid orally and injected to stop the bleeding. A small note on pandemic and palliative care. I strongly think if most of our doctors were trained in palliative care, we would have handled the pandemic better. It was tough, not just for the doctors, but for the entire population, medicos, non-medicos, patients, non-patients, rich, poor, elderly, young, everybody. So ideally, the way we could have done it better is been better support with each other, triaged patients better, given the right patient, the right kind of treatment. So there was no chaos about bed availability, run from hospital to hospital, and also the grief and the bereavement that followed, because there are families who lost more than one. There were families who couldn't see their deads. So there's so much in the pandemic that we could have actually dealt with better. With that, I stop the presentation on the fact that how in respiratory care we can actually integrate palliative care and improve the disease experience, not just for our patients, not just for our caregivers, also for us doctors. So if you have proper transparent communication, documentation, it is a win-win for all of us and less stress for all of us. And we will be able to practice medicine in a much more ethical and unstressful manner. So thank you. Over to you, Radha.
Thank you very, very much. As you have touched what is essential and everything as much as possible. And generally, one thing came up to my mind was they used to keep on asking, some of them used to have queries on terminal sedation. So I just thought I will put that question again so that if they used to ask, and we used to say, we have given some choices and options, and we used to say it will be covered. You do cover, and also in end of life care session also that gets covered a bit. So if someone wants to ask, please do ask now, because you took them through how is it done, and anything more they could clarify. And the one statement which I liked, the way Dr. Rajam Iyer said is, see, all of us, like mistakes, we are human beings, okay? We are not immortals. We are not right all the time. Okay, we may do mistakes, but how do we know that we can avoid that and reduce the same mistake next time and move forward? That is the thing, the attitude, nature, or inspiration, aspiration, everything should be that. For that, she's given us a clue. Okay, this is what we did. It was not right. How can I change? How can I be better? So that is something all of us could think and work towards getting better. Can we get the
One
article
last
on
thing I
morphine
want
for
to add,
sedation?
the getting better need not just be medically. I think I think I become a better person. And
Eggs.
post-pandemic, I think the most important thing is we all need to be fiercely kind towards each other and our patients. Once that comes in, automatically the attitude, the approach, the way you, the manner in which you treat your patient is genuine concern and can do to the best of your ability. See, if we cannot solve all their issues, but at least we can be a friend in their difficult journey. And it need not be that you're constantly living their life and pain, but even one SMS in a day or in a week, in a month, it makes a huge difference, especially if I can think that a lot of you must already be caregivers to your loved ones. If your treating doctor actually asks, how's your mother or how's your dad? Are you okay? It makes such a big difference. And that's all it takes. It's not even a second to type, how are you? Or you can just forward, cut, paste, how are you from somewhere else. Point is that you thought of that human being to be there for your patient.
Just the human. What it's already there. It's there within all of us. Just being humane. That's all. Because like with this routine, mundane rat race running or whatever you can say, that has been just hidden. So just tap it and bring that out. And that makes, and as you say, I always used to say, whenever anyone starts to practice anything chronic issue management, you will see how much it changes the aspect and the life for yourself also. So once when you start seeing that, oh, why should I only be happy? Let the whole world be happy. Let everyone understand. So awareness. So next comes slowly. See, just as Dr. Rajam mentioned, I would also like to say, like many of my friends, when I tell this, they say, oh, it's nice that I also know about it. All non-medics, I'm telling. They'll say, we will attend some volunteer course also in palliative care because I have my mom and dad who are 85 and 90. So this is a statement I'm hearing from many of my friends now. So I'll say, okay, you attend that 5-day program. And then they'll say, we'll attend. Then if we can help, we may help. See, first it starts off, I will try to know. In that itself, it goes to the second stage. They say, okay, I will attend. If I can do something, I will try to do. So see how much of benefit it will give to one and all. So regarding the sedation, does anybody else want to
They
ask
want
anything more?
articles. I will
Are
send the articles to Pallium.
morphine for sedation in terminal care.
Yeah, that I will send the article. And
Okay.
the 2 articles that Pallium needs to send is the gold standard and the blue
maple.
Please send it.
Blue maple.
In fact, I think that should be a part of, like your welcome pack. Such an important document.
Okay, so that I think those are also explained and said again in end of life care also.
Okay.
They are mentioned. So anything else anybody wants to ask? The breathing, thinking, functioning is very, very important. And I think when we dealt a bit on non-cancer illnesses, palliative care in non-cancer illnesses also, it was touched. So that is something, is everyone clear with that, or anybody wants us going through that? Because that's such a vicious circle. If you don't break it in one of the chain links, unnecessarily the patient will be going down. So are all of you happy with it, or would you like anything more on that? Because that, I always say, that slide as such has the problem and the solution also in the same slide.
Parvati Nair, you want to ask something? Please go ahead.
Yes, ma'am. Mine is not end of life. It's more for patients who are living with sequelae of lung disease. So I have a colleague recently who reached out to me asking if I have any information on protocol for patients with TB who are cured but dealing with sequelae of.
Actually, it's interesting that you asked this question. We are actually in the process of forming a guidelines for TB in palliative care in TB, because unfortunately, a lot of these people are young with very bad chest sequelae of the illness. And the same protocol fits in. So if the patient, obviously here, there is even more counseling that needs to be done because the patient is also young, his intimate relationships are affected, his vocation is affected, and therefore a good amount of counseling, physio, and low dose morphine will be benefited if assessed properly. So we are in the process of forming palliative care for TB and even cure TB, but there's so much destruction in the lung, there's hardly any lung left. So it's just like interstitial lung disease where the lung is fibrosed or not participating in respiration. So yes, they do fit into the need for palliative care. So please remember that palliative care is not diagnosis or prognosis based. Palliative care is need based, and the need for every human being is different. So that is what is important. So if a person is not coping, he needs that extra support and hand, and that is where palliative care comes in. So it's not key TB patients don't need, only cancer patients need. It is not diagnosis based. And please also remember, there's a saying by a person, I forget the name, where the needs of all patients at the end of life is same. Whether the patient is dying of cancer or heart or diabetes, the needs are the same. So please remember that everybody needs that support at the end of life. It's not diagnosis based or prognosis based. It is only based on need. Yes. Chidananda Swami. Can you unmute and ask?
Yeah. This is regarding the oxygen therapy, what you are mentioning, madam.
Yes.
Regarding what is the cutoff which we can comfortably accept? We know that patient is breathless.
What is the meaning of cutoff? Is it
No,
pulse oximeter
what's the
cutoff?
lower limit on the pulse oximeter?
So first of all, there are things about the pulse oximeter. Okay, you need to check pulse on both hands before you put the pulse oximeter. You need to be sure patient doesn't have a red nail paint before you check the pulse oximeter. Third thing, you need to check the battery of the pulse oximeter. So check on yours before you put on the patient. Then if the patient is breathless and you think the oxygen will be low, and if it is below, so any 86 and below, 86 and above is safe. Okay, in a chronic patient. See, chalta firta patient, normal patient, 86 is gadbad. But in a chronic patient, anything above 86 is fine. Below 86 is when you should start oxygen or start increasing the oxygen.
Thank you.
If you remember your oxygen dissociation curve, the sharp fall is only after that.
Okay.
That's the logic.
Thank you, madam.
Thank you very much, Dr. Rajam, because that's very important. Pulse oximeter, and also you have to check whether the pulse volume is good, because what actually
the
the
capillary
physics
filling will not sense the oxygen.
Exactly, it's the physics underlying that is that. Okay, and one
and
more
also
thing,
not cold. See, sometimes patients can be very cold or in cold
jaundiced,
poor peripheral oxygen circulation. So you need to warm their hands or keep it under a bed sheet and then check. Yeah.
Okay. And regarding Dr. Parvati's Nair, like we had, she deals, I think they have a lot of patients with tuberculosis who are totally unresponsive, like total drug resistant TB patients. So she was mentioning about that. So they do deal with those type of patients.
So
very young,
MDR
not responding.
It's a financially also a huge problem. Plus they are, they are infected patients. So they have to be isolated. That is also scary. Then they lose jobs because they're MDR TB. So it definitely needs palliative care. There is no doubt about that.
Is there any assistance or anything? I think she is from Mumbai. Am I right?
MSF is the one which helps TB patients. Doctors Without Borders.
That's what. She works for that only. Am I right, Parvati?
Ma'am, not at the moment, but in general, MSF, yes, I worked. I'm working with MSF now, but not with MSF Mumbai because we shift between projects. But I will say, ma'am, that there's a lot of discussion about how we can provide morphine. So I can't speak for the project
yet. So the problem with morphine is that you need to be trained in palliative care to be able to prescribe. And the problem is that people still don't realize who can stock morphine and who cannot. According to the 2014 NDPS Act, it has to be a registered medical institute, which MSF is not. So you need to tie up with palliative care to be able to access morphine. It is available in Mumbai, but you cannot prescribe it. So it's a very foolish reason for not giving your patients, but we need to find a way about it because MSF is not an RMI. And RMIs can apply for morphine registration.
So they may get in touch with another RMI in Mumbai.
Correct.
They can refer the
Or
patients
palliative
there.
care NGOs. You know, Bombay has two, Palcare and this thing, Romila Palliative Care. Their doctors are assigned for it. So you can actually take their help to look after your patients.
See, those are things. See, actually, the whole thing, all of you, I keep telling, every time, every batch, I say this. See, whatever 55, 60 of you, you have got 60 friends now, okay? You all help each other. So that is how you can make your lives also easy. So this platform, and you've got PALIM also, the regional coordinators. So what is the rule that you all should not be happy and comfortable practicing? So utilize this platform, get the help, get the assistance, and make your patients comfortable. And as a result of that, all of you also can be comfortable also. Okay, in that, is there anything else in the chat? And then in the otherwise we can.
So they'll send me emails to remind me, then I can share the articles.
Okay. In that case, shall we go on to the case presentation?
Yes, ma'am. Slides will be shared, or shall I share
Yes,
the
yes,
slides?
Sharing the slides. I just saw Dr. Swami had raised hand in his suggestion.
Yeah, then I saw.
I thought it was it. Okay, go ahead, doctor.
Yeah.
I thought he had not taken it off.
No, I just want to ask, madam, see, what is, of course, this is not out of this thing, consideration for this tracheostomy on this long-term patients, how do we go about it? Do we?
So which kind of, so these are important to discuss beforehand. Usually tracheostomy is done as an emergency procedure. So if you have a patient with chronic obstructive lung disease whom you know is not doing very well, or ILD, or say, maybe motor neuron disease, we discuss all this with the patients beforehand. Do you want a hole in your throat? I'll let them understand what they're getting into. If no such discussion has happened, then you have to do everything. Problem is that we never discuss. We only don't start those conversations.
Because because I manage neurocritical care. So what I thought is, because we keep getting these patients with
True, but you need to realize, is tracheostomy improving quality of life or prolonging poor quality life?
Yeah, that's what, because sometimes the patients themselves ask, they go, somehow they would have got into the ICU, they're all intubated, they're on ventilator. There's a way because we want to get some via media where we can get them out of the ventilator.
True, tracheostomy can be used as a good way to wean the patient off ventilator, but you also need to tell them about the fact that what if you are not able to? See, what we do, we tide issues as we face them. But you and me have seen 100 more patients. We should be able to tell them the issues before we get into that problem, right? That this can happen, give them the time. They cannot think in ICU on the ventilator how to do. So these discussions, see, unless it's an acute event. If it's an acute event, you fight tooth and nail irrespective of the. But if you have known a background person of COPD, background of interstitial, has no business getting onto the ventilator.
Yeah, because sometimes what has happened, at least what I face is sometimes in a different center, they have tube put on ventilator and then they transfer to us. So already
the point is again, doctor, if you've had an advance directive, so what is the process? We need to start disseminating that knowledge. Any chronic, incurable, progressive illness, the doctor's onus is to say, do you know living will? Supreme Court has passed a judgment. Please share that paper also with them of Jan 2023 gist of the Supreme Court that living will be accepted. Supreme Court has made the logistics also much easier. So it is our right to know, right? All of us are happy talking about estate to son and house to daughter, financial will, we are happy to talk about. But you also need to talk of how much torture you go through at end of life. Why should you go through that if you know you have an incurable progressive illness? It is our duty. Yes, very often we say that in the local nursing homes, patient is intubated and sent to you. But you can also extubate the patient if you feel that it is not in the best interest of the patient. Compassionate extubation is withdrawing treatment which is legally, medically and ethically allowed. Point is, none of us are comfortable. I have extubated so many patients during COVID and subsequently. Extubate, keep the patient comfortable, send the patient home or send the patient to the ward to die in peace.
Thank you. Thank you, madam.
So it's important to understand withholding, withdrawing, the legal aspect, the medical aspects, and the ethical aspects. It's the same thing. The intention is comfort. The intention is not to end life. But yes, life can end is a fallback of that. But you have removed the tube because it is really no use putting the tube. It's just making the hospital bills bigger.
It's a collective medical decision, isn't it,
Yeah,
Dr.
yeah.
Rajam?
It
It's
cannot
just
be
not.
your own.
So that's what. So always see if the patient has come and they will have a regular treating physician.
Yeah.
Even though the patient is new to you.
The intensivist, the primary physician, and a
Correct.
third palliative care physician of the hospital. 3 doctors, and you need to have 3 signatures of the 3 relatives. It is not easy. I always tell that it takes 2 minutes to put a patient on ventilator. It can take any time from 2 hours to 2 weeks to 2 months to not to put the patient on.
Yes.
But are we ready to spend that much
decision
time?
is what convincing the primary care physician sometimes becomes difficult. That's what I have seen.
I completely understand. The biggest obstacle we have is hospital consultants, because for them, like the joke that goes around corporate hospitals, the rich cannot come out, the poor cannot go in. It is a money-making racket. Unfortunately.
Exactly. So
there is no logic. And believe me, very often the arguments I've had with consultants is, would you put your mother and father in the same way? The answer is no, because maximum referrals come to when there is their own kith and kin. But it's the patients, they don't refer. And they never would want their people to suffer. It is suffering. Na? Nobody budgets the suffering. So there's a lot of work for us to do. And thankfully, every batch has about 40 odd. So we hope this word spreads.
Thank you. Thank you.
And that's what. It is a big challenge. It's not going to be easy. And like even many times our own colleagues will be barriers. Okay. So because awareness again, it's a matter of time. And especially as Dr. Rajam said, no, if it is your mother and father, will you do? If next, there are so many articles also on this, like about this decision, varying decisions. If you're all happy, I think I have an article, then maybe if you're all willing, I will share in this group. There is a decision what a doctor makes and what a doctor makes for the patient. What a doctor makes for himself or herself and what a doctor makes for the patient. I will, if I can find that, I will send it to you. So it's a challenge, but everyone will understand and move a little bit of, like we say, steep learning curve. It will be a steep learning curve and we will all get there. And no, it's not a single decision. No, at no time it should be a single decision. It should be multidisciplinary decision and documented appropriately by all the members of the team with clear clinical evidences. So none of these words, all my words are important in that. Okay. If you're all okay, we'll go on to the case presentation.
Thank you, madam.
You're welcome.
Shall I start, ma'am?
Yes, please.
Good evening, all. Myself, Dr. Deepa. I'll be presenting a respiratory case. Next slide. This is the detail. 71-year male diagnosed to have COPD with the underlying lung condition carcinoma. History of presenting complaints. History of breathlessness for past 1 year. History of cough for past 2 months. History of left shoulder pain for past 1 month. And loss of sleep for past 2 years. History of illness. Detailed history. History of breathlessness for past 6 years. Aggravated by walking. Relieved by rest and medications. Increase for past 1 year and more so in for past 2 months. History of cough 2 months. Scant in amount. White in color. Not foul smelling and not blood stain. History of left shoulder pain for 1 month. Not radiating in nature. Not associated with chest tightness and relieved by medicines. Past history, history of treatment for lung carcinoma, right middle lobe carcinoma. Radiotherapy was given, and here's history of previous hospital admissions for breathlessness treated with oxygen therapy, salbutamol inhaler, antibiotics. Personal history, he takes mixed diet, he's a smoker for 20 years and stopped for past 30 years. Appetite is reduced and his sleep is disturbed. General examination, is conscious, oriented, cooperative, thin built, height 5.4 inches and weight 53 kg. Pala present, grade 2 clubbing seen, no cyanosis or icterus, no generalized lymphadenopathy. Skin hyperpigmented healed scars of varicella zoster is seen on the thoracic segment. Vitals, blood pressure 120/80 recorded in right upper limb in sitting position. Pulse rate was 98 beats per minute. Respiratory rate 22 breaths per minute. Saturation 84% in room air and with 4-liter oxygen support 94%. Respiratory system, normal vesicular breath sound is heard and there is decreased air entry in the right middle zone. No added sounds. Cardiovascular system was normal. Abdomen was soft, not tender, no ergonomegaly, and higher mental functions were normal. Next line. Treatment and other investigations done to this patient. Hemoglobin was 14 gram per deciliter. Total count was normal, 4,280 cells per cubic millimeter. Platelets was normal. And ABG was done. It showed respiratory acidosis. The chest X-ray of the patient. You can see the hyperinflated lung field with prominent bronchovascular markings and widely separated rib interspaces. In ECG, you can see sinus tachycardia. Next line. Psychosocial aspect of this case. He's an elderly man supported by his wife. He has no children, no income to support him. He survives his bank savings and is too much worried about his future. His wife, though she's supportive, she's chronically insomniac. She's worried about her husband's breathlessness and also afraid to live alone if he passes away. Medications given to the patient, nebulization, Foracort and Diolin, syrups morphine 1 ml twice daily, syrup Ascoril, tablet tox carbamazepine for his pain, varicella zoster pain, and tablet pregabalin, injection derifilin, tablet Nagfil, tablet pan, Shelcal, Ensure protein powder, oxygen support 4 liters and overnight BiPAP support. Main concern on this case discussion is for this patient, main concern is breathlessness. He is dependent on oxygen. He has a neuropathic pain, chronically insomniac, depressed and over anxious. Summary of my case. 71-year male came with acute exacerbation of COPD, neuropathic pain, shoulder and on the left thoracic segment. Past history of radiotherapy for carcinoma lung and now on medical management for varicella zoster. For COPD, he is treated with nebulization and pain medicines. He is planned to discharge with home oxygen support. Discussion points. COPD and acute exacerbation symptoms, how it has to be managed. Neuropathic pain management. Depression in chronic illness, how it has to be treated, how he has to be counseled. Malnutrition in chronically ill patient, especially respiratory disease condition, how it has to be corrected. Treatment adherence and compliance, how it has to be explained to the patient. Family support, how gradually we can reduce the pain medicines, and prevention of radiation-induced breathlessness. Yes, ma'am. I have done with case.
So if you can stop sharing and then throw or keep one of the slides, these discussion points, and I throw it back to all of you. You have heard what all can be done. So when you have a patient who is 71 and you have a patient with COPD and lung cancer, who's on oxygen 4 liters, which is quite high per minute, and on BiPAP, what should your conversation be with his wife and him? How should it start and what should it entail? Have you all had a communication class?
Yes, yes. We have had 2 sessions on communication.
Yeah. So what is Spike's protocol? And why is it important? Because this man,
Anyone, like see the whole,
COPD,
all of you,
he has
anyone can
cancer,
answer.
he's got no money, he's got no children to run around. He's the ideal candidate for conversation. So what is the Spike's protocol? Or tomorrow, if such a patient sits in front of you, what are you going to do? Yes, we can start with the one who presented. So Spikes is setting,
Speak.
perception, invitation, knowledge, emotion, and summary. Correct? So what does all this mean to you? Now I made it simpler for you all also. What is Spikes? So when this person comes and sits into your clinic, you need to first ask him, what does he understand of his illness? Because he's so worried about the future, which is natural. You and me also will be worried. Correct? It's not what patients undergo is nothing that you and me will not. So you need to first understand what they understand of the illness. COPD is incurable. I don't know what stage of lung cancer he is, whether it's curable or incurable. So you need to first make it very clear to him about the condition. Once you explain to him about, how it is going to be incurable, a lot of things the patient will only say, I don't want to do this, I don't want admission, I don't want this, I don't want that. So your focus can be then on comfort care. And the comfort care will include not just his physical health, so counseling for his emotional health, social worker for his financial issues, his wife, she's going to be alone. She needs counseling. You need to plan her life as to whether she continues to stay in this place, go to her parental place, go to another ashram. I don't know, whatever that is. So you need to ask her what she thinks, because you need to you need to help her plan. And then your palliative care services should actually follow up during the bereavement. So the point is, for all this, you need time to establish respect, rapport, faith. Why should he or she trust you if he's just met you once? So you need to establish credibility, and only then they will have faith in you. So the fact as to no more hospital admissions, home care palliative team, better management of pain, not to do unnecessary. Now this BiPAP, oxygen is not cheap for this man who doesn't afford anything. Secondly, you're giving him shell cal. How is all this helping? It is only increasing his pharmacy bill. So give him medications that is going to cause comfort. Now, syrup, morphine, 1 ml, I have no idea how much is the morphine in it. And why syrup? Coimbatore doesn't have tablets.
1 ml, 10 milligram.
That's a lot. So even after that, if he's breathless, then we should see he's already taking 20 and still feeling so breathless. So there are other issues that's bothering him. Na? So first, you need to be honest with his condition. This is going to happen. This may not happen. This is going to be like this. In this situation, what would you like to do? Putting you in ICU, putting you on the ventilator is not going to make you cure you. So then do you want to go on it? I would suggest, you can only suggest to the patient, they need to decide, right? And you need to, therefore, once they make the decision, you need to support them on the decision making, because even after they make the decision, they'll be worried. Have I done the right thing? Am I giving up? So many things come. So a good conversation is really like a beautiful procedure done. That's why palliative care is also narrative medicine. If you tease out all the issues, have a summary, 1, 2, 3, 4, 5, it's much more clearer for the patient in the language he understands. Turn to the caregiver so that the patient also is happy that the caregiver will be looked after when he is not there. So it has to be a holistic discussion, which according to me, when you do it well, it's such a relief for the patient, for the caregiver, and you, because you have planned everything for the patient. No unnecessary casualty visits, no unnecessary ICU admissions, inform the primary consultant, morphine is given, plan to escalate morphine, what to tell the home care teams, how to manage the pain, all this is discussed. And please always include non-pharmacological. So massage, oil, hot water bag, that herpetic thing, I have felt, I'm an allopathic doctor. I know nothing about homeopathy, but homeopathy helps in post-herpetic neuralgia. Living example is my mother. Do not ask me for any scientific evidence, but try. What's the harm? Point is, patient should be relieved, right? So keep your options open. Just because we don't know it doesn't mean it's trash. You can seek opinion of colleagues who are doing something, acupressure, acupuncture, something or the other works for some people, right? Massages work, something works. You never know. Idea is that this person who's got COPD and lung cancer, the overall prognosis, according to me, is very guarded. Because COPD worsens the prognosis anyway of lung cancer. So importance is pain relief. So you can try all of this, but finally homeopathy is what worked with my mother. So it might, you need to be open to other suggestions. This is what I feel. Anybody has anything else to say? Please unmute or chat and send.
I was just thank you very much, Dr. Deepa. And a few things I wanted to ask you. Is syrup morphine available and where do you practice?
Ma'am, presently I'm in KMCH Coimbatore, and the treating
Government
physician-
hospital?
No, ma'am, corporate hospital.
So is syrup morphine available?
Yes, ma'am. The
Because
patient
syrup, we have tried for pediatric and we have never had syrup. So that's why I'm asking you. I was surprised when I saw your thing as syrup morphine. So is it freely available? Do you get that all the time?
No,
Because
ma'am,
I have
it's
had
not.
some
It's
patients
not for free. I don't know the exact cost of the syrup, but I do. I have seen prescription of my physician suggesting syrup morphine, and I'll get through the details of how.
Because normally, from what I have known about Coimbatore, tablet morphine is what that itself with great difficulty we have had. Okay, that is one side of it. Second, so far, how much psychological assistance has this patient or the family had? Have they had any consultation, counseling, anything with the psychologist so far?
No, not with psychologist, ma'am. They haven't gone with psychologist.
You see, what is total pain, dear? What we have been telling again and again, no? So see, that's the main reason. The benefit of all of you attending is that when you start seeing itself, you find out. So have we covered everything? So just by treating the physical pain alone, what is the definition of pain? Biopsychosocial. Just take us. I have a headache. Okay. When I have a headache and I have other issues going on, my headache is 10 times. And we have given you so many examples. So slowly, incorporating like that, no? And this is the problem. I just, in my routine, seeing all patients, I will sort this also. It doesn't work like that. Okay. All of us, whenever we see patients, we have 10, 20 patients to see. But in that itself, you want to cover this up, it will not work like that. So these type of patients who need extra time and care will wait. You will finish your routine clinic or practice or whatever it is, spend some time peacefully with them. Only then they will also open up. If you show that you're very rushed and things, the patient themselves won't open up. Oh, if I say this, where is she going to listen to me? I will also be in this. I don't know. I have been on the other end also. Okay. All of us would have been. When you go to the other, when you are on the receiving end, you will know.
We have one physician, ma'am. She's to take care of this palliative aspect of patients. She has started to do it, and she regularly visits the patient and gives consultation. And she being an anesthetist, she is able. The treating physician refers to her for further counseling and
that's
follow-up.
so always, as they say, no, psychology plays a big role. That's why we say at least one doctor, nurse, and a social worker or a psychologist will be a good team, because many times, and it takes time. They will not open up. We also have to give them some room, space. That is what is spikes. What is it?
Also, I think the problem here is I have also faced private hospitals don't employ counselors, etc. that easily. That is a problem. But then you can train yourself too. At the same time, a social worker is not that expensive for a hospital to have. Right?
Correct.
It benefits, because a lot of unnecessary communication where medical things can be done is then, you
Correct.
waste time doing what a social worker can do. So I think a hospital needs to see the value of these things, because it's really care experience. That is something that corporate hospitals sometimes forget. The fact is not that state of art has heart transplant, lung transplant, but the whole manner in which the patient is admitted to a hospital, or good morning, how are you, that basic sense is not there. The care experience, the way patients are cleaned in the ICU, the way patients are transferred from the trolley, stretcher to the bed, all these things are the way you treat human beings, right? Those are important things.
So that's all. See, why are we all telling again and again means because, see, as doctors, we have plenty to do. We never, same thing, 40 patients if I see, I will not have time. So these people, we all work together, team working, and then the beneficiary is the patient. Okay. So because so many issues and concerns do come up whenever we do case presentation, no? So with all that, we need to tackle them, but one person tackling everything will not be possible. And slowly, you will also gain some additional skills and things as you start practicing, that these are also additional skills, like especially when you see the patient and your body language, as you saw in communication, no? Non-verbal communication is so much. As we say, don't even go to patient. In your house, you see. Day-to-day living, you all see with your house or family, with friends, with colleagues, everything, all what is taught in these important, these communication sessions and all, you just start to think of that when you start doing that anymore. Many of the times, like even when we did a face-to-face course, some of the doctors who were in that, even on like 5th day of the course itself, they came and said, Madam, we've already started realizing in my yesterday's on call, I realized how I am talking to my patient, what I did. So that was the feedback we got. So like that, you all have to put things into practice. And then see these social workers, psychologists, they all play a big role. So if they teach them some techniques, all these things, what we say, like cognitive, there's something called as cognitive behavioral therapy, which is taught by the psychologists. How to manage and deal with tough situations. That is what they teach. Because our thought and thinking overtakes our action. They will teach them how to train our brain on how to work in our favor rather than being against us. So these are very many things, and so it does help. There is an entire psycho-oncology itself is there. Clinical psychology, psycho-oncology. There are so many things in that. And psychologists are the most rarest all over the world. It's not only 1 or 2 places. Globally, it's like that. But there are people. And so those things have to be taught, like ways and things. Spend some time, talk to them, find out what are their issues, and give them confidence and that you're not going to abandon. Oh, if this treatment is not given, don't think I'm going to leave you. This treatment will not be helpful for you. So whereas symptom management will be helpful for you, and that we will continue all along. That is what the way you say, that is what they say, goals of care. You sit and talk to them, explain what it is, then give them time to understand, go back, come back again and tell me what you've understood. Don't do everything in one day. Nothing will go in, no result you will get. 2-3 sessions you need. And every session you have to make sure what you said has been understood and whatever queries do come back.
How much they have taken up from us and what they have digested from what we have explained to them. And the next session we have to build on what they understood, and then it has to be in sessions.
So you can ask them to repeat what you said. So you'll automatically get to know what they've understood. So for example, suppose you have said that, this is incurable, that this treatment is no point. I'm going to refer you to a counselor, etc. Said, have you understood? Okay, can you repeat what I have said? And they will tell you. You easily will know what. And the fact that when they repeat is not the same as what you have tried to tell, it doesn't really mean that they haven't understood. It also means that we are poor communicators. Or the human nature is to always point out that the fault is always the person in front. Introspection is not a very good quality that we have. But please remember that, there's a lovely saying where they say that the best conversations is never forgotten, is always remembered, and a bad conversation is never forgotten. So, it leaves a deep
Both
impact.
are the same.
Both are the same, yeah. But it leaves a deep impact. So, for example, say your
Yes.
driver or your staff has been rude to you or answered you back in a manner that he shouldn't or she shouldn't have, it leaves a deep impact on your head. Similarly with doctors and similarly with patients. And in fact, here it is worse because we are talking to people who are sick and suffering, not healthy people. So we should be extra cautious about how we say this. And I'm not saying you needn't be assertive. You can and you should be assertive in some stages. There are people who keep asking the same things. So you can be assertive to them, but it should not be rude. We do not have a business of being rude to anybody. Nobody, not just doctors. I'm saying anybody. Nobody has a right to hurt. You can't benefit, help people, it's fine. But it is you do not have the right to hurt people. Full stop. Okay. Anything else? Please send me emails on what topics you all want the articles. I've shared my email address on the chat. I'm happy to share the articles. Thank you, Deepa.
Thank you very much, Dr. Rajam Iyer. No word to say. Pass it on to Sri Priya.
Yeah. Okay. Thank you. Have a good evening. Namaste.
Thank you, Rajam ma'am. It has always been wonderful listening to your energetic sessions, and today was no exception. Thank you so much. And we do expect to have more such interactive sessions with you in future. Thank you everyone for joining in with the promise that we'll be meeting again with another different topic and another eminent faculty. This is Sri Priya along with Dr. Rajam Iyer and Dr. Rata Venkatesan signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Keep spreading happiness. Bye-bye.
Thank you. Wonderful.
Thank you.